So when we're looking at routes of administration, we have to consider a lot of different things, but one of the biggest things is how fast that absorption rate is going to be. Some medications, in a pre-hospital setting, they need to be given right then, right there, and we don't have time to wait for a very slow absorption rate. So this is why we don't give a lot of medications orally. There's a few, but not a lot. We really need things most of the time very fast. So as long as you understand the rates of absorption, this may help you when you are deciding what route you want to give if you have different options. So we have two primary routes of administration for the medications to get into the body. So we've got enteral and parenteral. So your enteral is going to be any kind of route that passes primarily through the intestinal tract, the GI tract. So this is going to be your oral or PO, your orogastric or nasogastric, your sublingual, your buccal, and your rectal. Any medication that does not pass through the GI tract is called parenteral. This would be like your topical, your dermal, your intranasal, subcutaneous, IM, IV, endotracheal, inhalation, intraosseous. And there are pros and cons for both of them. So for your enteral, some advantages. It's simple. It's relatively safe. There's not nearly as much potential for infection. And generally, it's less expensive to give these medications. Some of your disadvantages. It's slow. It's a much slower rate of onset. So if it's something that you need right now, it's probably not going to be the best option. If they are unconscious or nauseated, you can't give them medication. You don't put anything in the mouth of an unresponsive patient, right? If they vomit, any medication that you just had them ingest is probably coming right back up with it. And your dosages can vary significantly based on their personal digestive setup, the condition of their intestinal tract, their enzymes, their acid levels, things like that. Now for the parenteral, some advantages. It's generally very rapid. It's fast onset. You can give it to somebody if they're nauseated. You can give it to them if they're unresponsive. The dosages and actions are much more predictable and reliable than your enteral. But your disadvantages, administration is usually going to be a little more difficult. You may have to start an IV first. You may have to insert an IO first. Usually more expensive. The side effects tend to be more severe than your enteral routes, and you have a higher potential for infection because usually these are going to be percutaneous. Okay, so going through the enteral routes, you've got oral. This is probably the most convenient way, but usually is a delayed onset of 30 to 45 minutes, so we don't use it a whole lot in EMS. Probably the most common oral medication would be aspirin, which we have them chew up and then swallow. Then you've got your orogastric or nasogastric tube, and usually we only do this if they already have a tube in place, but in some areas you may be able to actually place an NG tube and administer medications if needed through the tube. Sublingual is where we place something under the tongue, and this is actually one of the more rapid absorptions for your enteral routes. Now, it's worth noting some books do not consider this or the rectal to be enteral, even though they involve the GI tract technically, because they don't pass through the liver or the stomach to be broken down. Your buccal medications, this is where something is placed between the mucous membrane and the side of the cheek. And then you've got your rectal, perectal. This is where you place the medication in the rectum and it is rapidly absorbed. This is more common in pediatric patients. You don't see this route very often with adult patients, nor do you see it very often with your EMS, your pre-hospital setting. Even according to current guidelines, they prefer, like say, the most common would be administration of a benzo in a seizing pediatric patient, but even now they are preferring your IM medication over your per-rectal medication. Your parenteral routes. So with your IV, this is probably the most common EMS route, and your medication enters circulation rapidly, but there's a lot higher risk of adverse reactions, so you need to take it with some precautions there. Now you've got IV bolus, which is just a rapid administered amount of medication instead of an infusion over time. We give these medications to get an immediate onset to obtain the highest possible blood concentration of the medication as quickly as possible. Some of your sites might include the back of the hand or the wrist, the forearm, the antecubital fossa, the external jugulars. You can also use the scalp veins and umbilical vessels for infants and the superficial veins of the leg and foot if you can't get other sites. But basically you're looking at the peripheral intravenous sites. Now your intraosseous, this is a pretty cool relatively new in the grand scheme of things. It's a way to get venous access when you don't have a vein that you can access. So this is given with a needle that is actually placed in the medullary canal of the bone, and the medications and fluids are administered through it. With this, virtually all of your emergency medications can be administered through the IO, and the onset of action is almost identical to that of an IV injection. Your sites can be your proximal tibia, your distal femur for your pediatrics, your proximal humerus, and in some areas you have the sternum as well. There's several different methods of accessing the IO, drills, mechanical, just depending on where you work and what you have available there. Your endotracheal once was a mainstay of medication administration, but now it's not recommended for the most part. Now, the medications can be absorbed through that membrane in the respiratory system, and it's okay. And with this, do they have fluid in their lungs already? Things like that. This all really affects how the medication is going to be absorbed in the body, so it's not super reliable. The other thing to consider is that if you are administering a medication through the endotracheal tube, the dose of medication has to be increased 2 to 2.5 times the intravenous dose. So let's say, for instance, you're giving epinephrine, okay? You're giving cardiac arrest epinephrine, so you're giving 10 milliliters of 1 milligram of epinephrine, right? Well, if you need 2 to 2.5 times that dose, that means in order to give 1 dose of epi, you've got to administer nearly 20 to 25 milliliters of a volume to get that drug in there. Added up, that's a lot of volume in the lungs over time, over the time of that code. So it's really definitely not the primary route, and it's really not a preferred route. They much prefer IV or IO when giving medications because of that. Now, inhalation is where you have an aerosolized medication that's inhaled through the respiratory tract, and it actually works pretty well. Probably your most common ones that we think about would be like your albuterol or other beta-2 agonists, things like that. But you can also have racemic epi nebulized, mag sulfate nebulized, and when they are given that way, they have the beta-2 actions. They decrease your mucus, they moisten the tract and thin the mucus if it's present. They work pretty well and very rapidly as well. Inhalation typically can reach and get within the body and start working within seconds. You also have intranasal, and this is where you give a medication without having to have IV access, and it works pretty well, and especially in children. So one of the more common ways that we give this, or things that we give intranasal, is going to be fentanyl, which works really well because we can give them really fast pain relief without having to get that IV access first. There are some other medications. The sedative midazolam or Versed can also be given IM. So, good thing to consider. Plus, it's safer for us because we don't have to have a needle to administer IM or anything like that. So, it's a little safer, less risk of a needle stick for the provider. Now, subcutaneous is where we give an injection directly into the sub-Q layer of the skin. It's slower but sustained. But there is a limitation as to where you can place it and the volume you can place it. For your intramuscular, it's more predictable. It's a little faster than your sub-Q, but it's not as rapid as your IV. And then, of course, you've got your transdermal or topical. And this is where medication is absorbed through the skin. It's varied. The rate of absorption is varied based on patient factors, how much you put on. Now, with your intramuscular sites, with your IM shots, these injections are going to be faster, like I said, than sub-Q, but slower than IV. And their onset is usually going to be about 10 to 15 minutes. Your common sites are going to be your deltoid and your gluteus muscles. And it just depends on how much volume you're given and where the easiest place to access on your patient is. Generally, about 5 mLs of fluid can be administered IM, but you've got a maximum of 1 ml in the deltoid, but you can give up to potentially 10 in the gluteus. So it really just depends on what volume you're given. If you've got a small amount of medication, you may want to give it to the deltoid because that's probably going to be easier access for your patient. But if you've got a larger volume, you may need to consider giving it in the gluteal muscles so that you can give a larger volume. For your sub-Q, You know, like I said, this is slow, sustained release of the medications, but we can really give much smaller volumes of liquid. Some books say 1 milliliter, some say 2. But we don't have a whole lot of medications that we're going to be giving sub-Q, but the injection sites are going to be away from the bone and major blood vessels and are going to be like over the scapula, the lateral aspects of the arm and the thigh, and then the abdomen, because we don't want to accidentally give this directly into the blood vessel, because usually this is designed to be absorbed a little bit slower.